So this is going to be a continuation from the first one, and I'm sure many of you have heard this story. 37-year-old lady, 20/40 vision in the right eye, 20/20 in the left, which was within normal limit. That's the family history of cancer. Look at those big blood vessels, and she had a big tumor behind them. More information for you. On 11/15/2017, that was the day of the presentation, 32 weeks pregnant. Have you heard of this story? You did. Okay. So with twins. Now you heard the story. Okay. She was scheduled for a C-section around the Christmas time, so like 6 weeks later. And the patient is from Huntersville, North Carolina. So there were, I don't know, like 50 emails between the OBGYN doctors, the anesthesia team, ophthalmologists, medical oncologists, radiation oncologists, and I can go on and on. And what was decided? Well, she wanted to have the treatment, and everyone agreed before the C-section. So what the plan was, well, let's move her from the eye center into the main hospital so the twins can be monitored during the surgery. The plan for the surgery was a biopsy and wait for the results right there, confirm the diagnosis of melanoma, proceed with the enucleation, okay? And then, I mean, enucleation is 1 hour surgery, right? The results were confirmed the melanoma. The eye was removed. It was a uveal melanoma, mixed type, and the cytogenetics was a class 2 brain positive. Now, she had an uneventful C-section as originally planned. That is not true. The C-section was planned for a Friday, and I called her Thursday night to check on her and see how she was doing, and she said that she's great, that she was ready for Friday. Well, she called me 3 hours later with a picture of the twins. So what I've learned is do not call your pregnant patients and you know, the night before any plan is made. And this is she, and I said, well, be careful with Facebook, be careful with what you do, be careful with the media, etc. And well, she did not listen to me. She was on the People magazines. I received these from England. So she was all over the place. So before I go on with the options of treatment, there are different ways of seeing life. You can decide where you're at. You have full, you're half empty. But in my mind, there is no doubt that everything to be successful is teamwork. If I feel that everything depends on me, I am not going to be successful. Successful means, in this case, beat the uveal melanoma. We need to win this battle. It's a war. And the first patient I treated was in 1992, and this has been in my mind since then. The team doesn't start with the doctor or with the technician. The team starts with the patient who answers the phone, the patient, not the person who receives the fax with the referral, and ends at the moment of the patient checks out. And then radiation oncology, medical oncology, oculoplastic surgeon, and the patient and their families. So I couldn't believe when Sarah showed those comments from Greg about team. And I agree. Together, we achieve more. That doesn't mean we need to agree on everything. That means, somebody taught me that we learn from the disagreement. We do not need to agree on that, but we can plan together. So I I was talking with Dr. Carvajal after the presentations yesterday, and we agreed that this is a different presentation for all of us because I have a presentation in 1 hour at UNC for doctors with the same title. The presentation is completely different. In here, we need to, how can I say? This is the engine, all right? But this is the tool. So, and we cannot, yes, we should follow the passion, but we as doctors, we need to be careful about the passion coming from there. We're trying to use our scientific knowledge to make things better. But we cannot do that without the teamwork. So I'm going to jump into, because of the time, I'm not going to tell you another patient story. But I'm going to start here. Treatment for uveal melanoma. Enucleation continues to be one of the options. Radiation, radioactive plaque, proton beam, others. This has not changed. Everything is about the same than 50 years ago. Transpupillar thermotherapy, that's kind of new. That's a laser. I'll show you some examples about that. And tumor resection. But these are the goals. Life number 1, eye number 2, vision number 3. Believe it or not, there are some patients who do not think this way. They put vision first. Am I going to lose vision? And we do know, I mean, we cannot feel exactly what you feel, but we do know that patients who are diagnosed with uveal melanoma, they feel like they're alone and they feel that they're unique. Who has an eye tumor? Well, we know about that. Which patients are going for enucleation? Well, huge tumors around the optic nerve. There was a change in the plaques. The ones at the top are the COMS plaques, and the ones at the bottom are the plaques that we're using these days. And you can see the difference between the COMS plaques who were 3 millimeters thick, and we are using either the BEVIC or iPhysics, who were 1 millimeter thick. What's the difference? Well, you can slide the thinner plaques underneath muscles, so you don't need to cut muscles. Patients will not have, or they are going to have less chances for diplopia, which means double vision, etc. What happened with the transpupillary thermotherapy, TTT? In the 90s, it was like a big hit. Why? Because everyone was driving crazy how good the eye looked and the scars looked. But the problem was that 5-10 years later, they have really, really bad relapses. So we use the TTT mainly as an adjuvant treatment for brachytherapy. Now, something at least new in our institutions is the stereotactic body radiation therapy. And we use these for big tumors. This lady, a young lady, she's 40, she was 40 at the time of diagnosis, about 2 years ago, I think, and she had this big tumor in the right eye. That picture is from March of last year. And after the stereotactic body radiation therapy, this is how the tumor looks. So just to rephrase that, you can see on the ultrasound how tall it was and how it came to less than that. I'll be happy to answer any questions. Thank you. Are we good for questions? Or, yeah. No questions? Yes.
On the patient caregiver Facebook page recently, there was a question about donating blood after you've been treated for ocular melanoma.
No. You cannot donate blood if you have a history of uveal melanoma. And there are some reports, at least one of them that I'm aware of, and there were two patients who developed metastatic uveal melanoma for kidney donation, so we need to be very careful with that. We tell our patients, do not donate blood.
Can we share that with the American Red Cross, because they look at it as a 5-year marker, and then you can?
Well, this is one of the questions that may not have straight answers, but why does uveal melanoma metastasize to the liver? And that goes through blood. So, yes, patients have the immune system who can react, but that's not always the case because those patients might be immunosuppressed, and that's when you don't want things to happen. So, patient can discuss with their doctors, but personal opinion, I advise our patients to not donate. Yes.
How long have the smaller plaques been around, and are they as effective?
So, how long? Long time. During my time at Wills, those were the only plaques I knew. And that goes back to the 90s. They're the same effective because the calculation, the software calculates the radiation dose to the top of the tumor. So it's the same.
The risks associated, or the risk associated with the larger plaque that you mentioned, the double vision, is that something that would manifest immediately, or could that occur later? It's immediately.
It's immediately.
Okay. So I had the larger plaque, and I haven't had.
Not every patient will.
Right.
But if imagine the eye has one muscle here, one muscle here, one here, and one here. If you put it in one of these quadrants, that's going to be fine. But if you need to slide the plaque underneath the muscle, you will need to cut the muscle. Some patients can develop that. Not all of them, but it's more common. I mean, the strabismus doctors ask me why they're not receiving more referrals from us. Well, we changed the plaques. Yes?
I guess two questions. Can you talk a little bit more about the stereostatic body radiation therapy, what that is and why that is?
Well, it's another way of treating with external beam radiation. And trying, right now is another weapon that we are considering for larger tumors. So what I advise the patients is to have a consultation with the radiation oncology team and with the oculoplastic team who might be doing the enucleation, and then the patient decides. So, this is not the first type of external beam radiation used. Proton beam has been used in Boston for many, many years. Some institutions use gamma knife. This is just another one. But to be honest with you, it seems that we're going to get the proton beam next year, and I think that we'll be using more proton beam than this.
Thank you. And just to follow up with resection, is that the gamma knife, and when would that?
No, the resection is just removing, doing surgery, removing the tumor. So mainly in Europe, because the cost of iodine-125 is so high, they use other isotopes for surgery, so they use more either extra resection from outside or endoresection from inside the eye.
When would that be recommended versus secondary treatment?
Well, if you go to Spain, they're going to recommend that most of the time. We say, why make a big hole in the eye with all the morbidity that surgery has when we can have a treatment that can control at least on the eye the tumor with just 2 simple surgeries, 4 days in the hospital or outside the hospital, depending on the institution.
Thank you.
Yes.
Okay, question about surveillance and what you would recommend in terms of, so let's say you have a class 2 tumor, and how often you would say you should have surveillance for how long, and do you recommend the CT scan or MRI?
Thank you for asking that. And that's why I mentioned the NCCN guidelines, because 28 leading centers discussing that. That's number one. Number two, insurance companies denying this. And the NCCN guidelines is one of the tools to help patients argue with the insurance companies. That's one. Two, MRI is the best. It's the most sensitive one. It's more expensive, and it takes longer time for the patient. The CT scan is very fast, and if the patient has a suspicious lesion on the CT, the MRI might be required, and then abdominal ultrasound. Class 2 patients, we recommend every 3 or 4 months CT scans, chest, abdomen, and pelvis, and the surveillance will be like that for 3 or 4 years. And then as the time goes on, then we might move to every 6 months. And then when we reach 10 years, we might switch into abdominal ultrasound.
That was good, lead into my next question. So the only data I've seen is for up to 5 years. What are y'all seeing with class 2 tumors beyond 5 years?
I tell the patients we consider 2 milestones, 5 years and 10 years, and beyond. So no, 5 years is good because one of the peaks is around 3 years. So 5 years is a good milestone, but we'll continue at least for 10 years. Yes.
Going back to the testing, what do you think about PET scans?
A PET scan, and that was an agreement by medical oncologists, and Dr. Carvajal and Dr. Orlov can make more comments about it. But PET scan, I'm not sure is the best tool. I will not put that first.
I'm 11 years, so they're still doing me every 6 months, and I just had a recent ultrasound, and something showed up on the ultrasound, so they sent me for a PET.
So, well, that's fine because chances after 10 years to have metastases are not zero, but they're much lower. But it might be just a start. And if there are more questions, I'm sure that they will order or indicate an MRI. Yes.
So for a lot of insurance companies, they won't consider the MRI because a biopsy's not done. Is there anything in lieu of that could be offered to explain this explanation to this community for this small?
Well, is anyone from the insurance company here?
But this
You-
on the internet.
Oh, okay. So, all right, thank you. So, you know how they think. And, one is to decrease, one of the options, the goal is to decrease cost. Now, what at least we do is we make a peer-to-peer conversation. So I will say, work to the doctor, and the doctor, my test has been denied by the insurance, and I will say that most of the time it is being approved. So, but it may require peer-to-peer, and sometimes we need to send articles.
But does the biopsy increase the risk of metastasis? Is that?
Well, yeah, so the biopsies can be done for 2 reasons. One is for diagnosis and the other one is for prognosis. All right, so, and if it's required, I mean, most institutions, I think, do biopsies these days, at least for prognosis. We do that routinely, so there is a good explanation why right there. And if they need that, we'll send it. I don't know if that answers your question. Yeah. Yes.
There's been a lot of different conclusions on prognosis given size, given gene expression, and one thing that Dr. Harvard published, it's been quite a while ago, is class 2 tumors and this gray area of plus or minus 10 millimeters. 12. 12 now? Okay. Is that still something being studied, or is gene expression more important than size?
So I'm going back to the NCCN guidelines, because all has to be considered. it's not one or the other. So why some class 1A patients develop metastases, while some class 2 do not? And it seems that the cutoff for class 2 who do not develop metastases, it's a largest basal diameter of 12 millimeters. Larger than that, higher chance, but lower than 12 millimeters in basal diameter means less risk, even in class 2. And that is, there are red flags. Many of us think that the earlier the treatment, the smaller the tumor, the better. Thank you.